Good afternoon, and welcome to this edition of HDSA and Me. Today, we welcome Dr. Deborah Hall, who will be talking with us about how to get the most out of your telehealth visit. You can send a question at any time during the presentation. Just click on the chat function in the toolbar, type your question, and hit send. Your question will be answered at the end of the session. This presentation will be available in about a week on HDSA's YouTube channel. On March 18th, we'll welcome the HDSA Center of Excellence team from Washington University School of Medicine, who will talk with us about confidentiality and the electronic medical record. You can register for this session by going to hdsa.org/HDSA and me. And now a little about our speaker. Deborah Hall is an adult neurologist and movement disorder specialist at Rush University Medical Center in Chicago. She received her MD from Indiana University and her doctorate at the University of Colorado, where she completed her residency and fellowship. Dr. Hall has expertise in large epidemiological studies, clinical trials, and human subject research. She's been conducting research in genetic movement disorders for almost 20 years and runs clinical trials, gene therapy studies, and observational studies in Huntington's disease. She has an active clinical program that includes HD and other movement disorders and can be found every Friday in the HD clinic at Rush with her multidisciplinary team. And now I'll turn the broadcast over to Dr. Hall.
Great, thank you for the introduction, and thank you to the folks who have joined us today. And I know there may be folks who join us after today as well, so welcome to you. This particular talk, I'm hoping to give information to the HD community about how to get the most out of the clinic visit. And I think this is an important topic because HD patients have a limited time in order to visit with their care providers and hopefully their multidisciplinary team. And you want to make sure when you come in for those visits and you leave that you get the most out of the time that you've spent. We want to make sure too that we can help you as much as possible. That's really why the Centers of Excellence and the other HD providers are in this business. So let's get right into it. So this is an outline of what I'm going to address today. We'll first talk a little bit about the types of Huntington's disease clinic visits because there is more than one type, and so your needs may be met in different ways depending on why you're being seen. There are several formats of visits now. It used to just be an in-person visit with your HD provider, but in fact, we now have other options. We want to talk a little bit about how best to prepare for your visit and set goals for your visit. And then we'll talk about some of the things that happen at the visit, such as referrals or ancillary services. So let's set the stage. There are different types of HD clinic visits. If you're somebody who's in an HD family, but you don't yet have symptoms of Huntington's disease, nor you have not had gene testing yet, you may be interested in a pre-symptomatic testing visit. So this is someone who has not been gene tested and does not have symptoms, but would like to go through the process of learning more about Huntington's disease, maybe have genetic counseling, and then consider whether or not testing is right for that person. The second type of clinic visit is someone who has symptoms of Huntington's disease, and so they're coming in for care for those symptoms. And last, we will frequently see patients in the clinic who are having a research visit. Now, these are not exclusive from each other. Sometimes we'll combine visits when people come into the clinic. Even patients who are coming in for pre-symptomatic care, they may be wanting to enroll in one of our observational studies. So let's talk about this pre-symptomatic testing visit. So a pre-symptomatic person is someone who's at risk of having Huntington's disease gene mutation, but does not have any symptoms yet. What this visit typically looks like is that it ends up to be a combination of several visits. And this is really standard of care, has been promoted within the HD community and through HDSA as being really the best way to provide the information needed for someone to make a decision about testing. So these visits are usually with three different sets of people. The first is with the neurologist to see whether or not there truly are symptoms or whether there are not symptoms of Huntington's disease. So the neurologist will have an interview with the person who's coming in and kind of focus the interview on symptoms and signs of Huntington's disease. There will be an examination, a neurological examination, and there will be a discussion regarding goals of testing and timing of the testing. The next component is that the person coming in will see a neuropsychologist or a social worker, and the interview is then focused on a psychological history. That person will also tend to identify who the social support system is for that individual. And that's really important because if there is a decision to move forward with gene testing, we want to ensure that when the person comes back for the testing results, that there is somebody there who can have a second set of ears and to also provide some social support. The last component, which is a critical component, is the genetic counseling. And this piece we have even for folks who are in HD families and are very familiar with the disease. Because sometimes there's a little piece of information here or there that the genetic counselor can provide that maybe is a new piece of information for individuals. So the genetic counseling will frequently give an overview of how the Huntington's gene mutation is passed down in families and the impact of results on families. And the genetic counselor can help us direct if the patient needs additional, very specific counseling, such as family planning counseling. Sometimes that counseling is done by very specialized genetic counselors. Those visits will occur typically on the same day. And then the individual, if they appear to be safe and the fit is right to have testing, they will go ahead and have testing that day. Now, many times the pre-symptomatic testing visit is followed by a results visit in our practice. It's about 4 to 6 weeks later, and the same group of providers has that visit as well. And so it's kind of a familiar team to the person coming in, and they're ready when they all walk in the room to have that visit for the results. So let's talk a little bit about pre-symptomatic testing. This question comes up frequently when we are in the clinic with our patients who are coming in for testing. What we really want to know is why people want to get tested right now. Why are people coming in for that visit? And I think that that is a question that maybe folks don't necessarily have, maybe they have not fully thought through the answer to that question when they come in, but it's really important. And I think that in the context of the neuropsychological visit can be very important in helping us decide if this is going to be the right time for you and to counsel you appropriately if we think it's not. So for example, do you have a major life event coming up? Are you going to get married in a couple weeks? So if you're going to get married in a couple weeks, do you want to come back right after your honeymoon and receive test results? You know, we have to really think about the context and the timing of genetic testing because it's a lot of information to receive and it's a lot of information you're going to have to cope with after the fact. So we want to make sure that this is going to be the right timing. Now, if somebody appears to be safe for testing and the timing seems a bit off, there's a number of ways that we can manage this. We can hold the test result until 6 months later. We can go ahead and complete the visits that day, but then do the genetic testing sometime down the road. Or we can just wait in general until the person decides at some point that it's the right time. Now, sometimes that will be triggered with a life planning phase, such as family planning, when folks are wanting to know what ramifications this might have on potential children in the future. Sometimes patients are wanting to do life planning. Say, the patient is older and they're interested in moving across the country to be with their family, but they want to have some idea of whether or not they should go into independent living or whether they should go into a senior community. That might be a time at which they want to find out if they're going to be gene positive and develop the disease. Another piece of information that can be very helpful with the gene testing is, what's coming up in the next 10 to 15 years for individuals. And many times people who are at risk for Huntington's disease having a positive test result are also caregivers for other folks in the family, including parents with Huntington's disease. So frequently families want to make a plan for those individuals. Where is that family member going to be living as their primary residence? Who's going to be the primary caregiver? And sometimes we'll do gene testing for that reason so that families can do some preparation. It's really important when people come in for the pre-symptomatic testing visit to determine whether or not that person is ready for a positive test. Do they have a support person in place? Are they psychiatrically stable? Do they have life insurance in place? And all of these things we try to plan ahead of time before folks come in for the visit. So all of these issues are very important. And in many times they turn out to be more important than the neurological examination because many folks are without symptoms when they come in. And so we're really trying in the clinic to hone in on some of these items in addition to getting the information we need from the patient in order to help make a good decision with them. So let's talk a little bit about a clinic visit for a patient who has Huntington's disease and has symptoms. So if this is the case, you will go in to see a health provider. Now, it may be variable depending on where you live in the country. So in patients who live in rural areas with less access to an HD Center of Excellence, in fact, you may see a primary care doctor or a primary neurologist, general neurologist. A general neurologist is someone who may not have extra training in Huntington's disease, but is trained to see all neurological disorders. And many of our folks will even have a general neurologist and just come into the Center of Excellence because, when needed, or even once a year because they live very far away. Now, some of these challenges in getting into the centers have been decreased with the pandemic because we're now offering telemedicine. But essentially, there are a whole host of care providers that will help patients with Huntington's disease. And many patients will be ready, will wait until they're wanting some kind of therapeutic intervention to see a health provider. So what will happen is that we will order gene testing before the symptoms start. A patient receives a gene test result, but in fact, there's many years before the symptoms develop. And so we may not see them until they start to have some changes in the Huntington's disease realm, and then they'll come back to the clinic. Now, the care providers could be either a neurologist, it could be a physician assistant or nurse practitioner. It could be that we're engaging with nursing or social work, psychiatrist or neuropsychologist. And it really just depends on what set of symptoms that patient is having. In our clinic, we have a clinic with a whole team of providers, and that team is very flexible. So if somebody comes in and we recognize they have an urgent psychiatric issue, I'll walk down the hall and ask the psychiatrist if they can see the patient. I think many of the centers of excellence will operate this way, just to provide the best care possible for our patients. So what is the format of the visit? You can see me on the right here. This is my current pandemic wear with the mask and the face shield, although it seems to change every few weeks in how we're doing this. There are now two options for visits for Huntington's patients. One is the in-person visit, which is, the typical doctor's visit that you would have. These visits tend to run about 60 minutes for a new patient and 20 to 30 minutes for a return patient. Now, many of us who see Huntington's disease, especially in the Centers of Excellence, recognize that frequently these timeframes are not appropriate for a Huntington's patient. Our Huntington's patients are very complicated, and they have many issues that we can't get through in that time frame. But that's really how we are set up in the medical community. And movement disorders, those are really the time frames for new and return patients. So we try to somehow stick around there. A full neurological examination is typically done with an in-person visit. We will have the patient sometimes change into a robe, but usually it's just taking off socks and shoes. So I like to warn people about that ahead of time, especially in the middle of winter when they may not be prepared for that. And then, of course, right now we have a lot of additional requirements with COVID, and I suspect that those will relax a bit as the COVID pandemic winds down. Now, many of you may have done or may be doing in the future telemedicine visits with their HD provider, and these really have to be adjusted based on the stage of disease. Now, one of the things I've noticed with the HD patient population is that they may be depending on what stage of disease and what family is around, they may have just a little more problem getting connected as far as the telemedicine goes. And so what I would suggest, which is I think a suggestion I've heard in some of the other HDSA talks, is that you really want to check in early and be ready. Now, at the time of the visit, many of us are trying to troubleshoot as we go. And this happened even to me in clinic yesterday, where we were picking up the phone and using a combination of an iPad and a phone. And we just kind of do what we have to do to make the visit happen. But there are some techniques we'll talk about in a few slides that will enhance the quality of that visit. So let's talk a little bit about how to get ready for your visit with your provider. Now, one thing that you want to do is set some goals for the visit. And I think that all of us, when we go to see the doctor, we have kind of a list in our head of the things that we want to discuss. And then we get into the room and we forget 2 of the 3 and add on another 1 or 2. And then in fact, the visit turns out not focused on the issues you really wanted addressed. So I think that the best thing to do prior to the visit is to write the issues down. And if you can do that, if you are the patient, do it with a family member, because sometimes the caregiver or the family member will have items that they feel need to be addressed that might be a little bit different than the patient themselves. Usually providers can get through about 3 issues per visit. Of course, if there's a crisis, usually that is the crisis. That is the only issue we're going to be able to address due to time in the clinic. And then you really want to tell the provider about your 3 issues during that initial interview. If you wait until the very end of the visit, the provider has now focused the entire visit on what they thought were the main issues, when in fact you wanted them to address something completely different. So I tell people maybe before the neurological exam, you would tell your provider what it is you're hoping to get out of the visit today. Now, again, if there's a crisis, usually we deal with that crisis and we will put aside or postpone those non-urgent issues. Because if there is a crisis, then that really is going to be the focus of medication, of therapy, of our future plan. And then of course, it may be followed by a sooner visit. Now, what should you bring with you for that visit? I would bring with you any records from recent hospital stays. We want to see if you were hospitalized and why. Brain scans are also very helpful. So if you have had imaging of your brain, the best thing for the neurologist is to actually have those pictures on a disc so that we can open up the disc in the clinic visit and take a look at your brain. And sometimes I'll actually walk through the pictures with the patient. I think it's always fun to see what your brain looks like. So what should you ask about when you go in for your visit? Well, these are the 3 buckets of problems that we will encounter with Huntington's disease patients. There'll be problems with movement, psychiatric issues, or cognitive issues. So what are the common things that we might be addressing in a clinic visit? Well, chorea or abnormal movements is one of the more common issues, but there's a whole host of other movement disorders that we see. We see stiffness or rigidity that we call Parkinsonism, and this is very common in the juvenile Huntington's population, patients who are on the younger side. Dystonia, which is kind of a twisting movement that's sustained that we can see in the neck or in the hands. We will see myoclonus or jerking, a little bit hard to distinguish sometimes from the chorea. And then we see a lot of problems with balance and walking. And in fact, when patients start to fall, we really spend time trying to sort out how can we prevent those falls, because of course you can be injured. As far as cognitive symptoms, patients initially with the disease will develop executive dysfunction. So these are changes with the organization and planning that the brain will do. Over time, though, you will develop other issues such as issues with memory, and this can worsen to what we call a dementia, which is a more severe memory disorder that's impacting your daily activities. Many patients with Huntington's will have a personality change. They can become more withdrawn and apathetic, or it can go the other way and become more irritable and aggressive. And so that's something that you would want to address with your provider if that's becoming an issue within the family. Now, lack of insight is in fact typically not a problem with the patient themselves. So the patient may not recognize that they have some of these symptoms or that the symptoms are a problem. It's really more of an issue a lot of times with the caregiver, because the caregiver is recognizing the symptom, pointing it out to the patient, and the patient saying everything is okay. And so that brings in the importance of having a caregiver or family member at the visits with the patient. Then there's these psychiatric issues. I already mentioned irritability and apathy, but we see a lot of anxiety and depression. And I'm here in the Midwest, and for a good 6 months, we don't see the sun. And so these sorts of things kind of come on a rolling basis. So during the season of winter, we see a lot more of this depression and anxiety and have to kind of cope with this with medications and light therapy and other things. Now, obsessive compulsive traits, delusional thoughts, and hallucinations can occur in varying degrees. We probably see obsessive compulsive traits more frequently, and those can respond to the same medicines that we might use for depression or anxiety. Suicidality also happens more frequently in the Huntington's population than in other populations. And one of those spikes where people are more at risk is actually around the time of gene testing. And so we're not only thinking about this if patients have symptoms, we're also thinking about it and those pre-symptomatic testing visits. So what happens in the visit? So when the doctor or the care provider, frequently the neurologist, is in the visit with you, they're going to be doing the same sorts of items at the visit. And the items that they do at the visit are going to be to assess your movement, to maybe do some screening of your cognitive function. They'll ask you questions about behavior, and many times there'll be questions about level of independence or function. Now, the motor exam is probably what folks will remember from visit to visit, because it's the same exact activities we're asking you to do. Move your eyes, move your hands, we'll feel the arms, we'll watch people walk up and down the hall. And what we do is we do this Huntington's disease rating scale. It's the same scale every time. And so the neurologist can see from visit to visit, has there been change? And that can help us when we're trying to make decisions about changing medications or starting medications. The cognitive function could be a quick screening test, or the provider may refer folks over for neuropsychological testing, which I'll talk about in a later slide. Now, assessment of behavior will come during that initial interview. Usually, unless people are actively hallucinating in the clinic, usually this is going to be reported by the patient and their family. And then, of course, the provider will ask the last questions about function and level of independence. So I know there's already been a talk on telemedicine through this program. I just wanted to bring up a few slides because this is very important. As we've been doing telemedicine, we've been learning more and more about this. And I just wanted to give a few more tips that have some pictures associated with them, because I think this may be helpful for folks if you're kind of a visual learner. So this particular slide talks about how to aim the camera during your telemedicine visit. And the hope is that you are going to be able to aim it to see this amount of you, at least for the interview part. And that allows your provider to see your face, to see your facial expressions, and if you're having problems with volume, to kind of be able to read your lips a little bit. Now, ideally, you would have a setup so that you're not touching the device or the camera, and so it's not moving around a lot. And on the patient side, you really want to have a setup so that you can see the provider's face. So again, it feels more like a regular clinic visit where we're talking face to face. So this next one talks a little bit about what the view is for an upper body evaluation. And so the upper body evaluation, what you can see is that she's now moved the camera back a bit, and you can see all the way from the knees up to the head. And so if you have this view, you can more easily pick up chorea or other movements. And this is obviously requires you to move the camera around. So I think one of the best ways for Huntington's patients is to have somebody with you during the visit. And if you're not very technological, having somebody who's on the younger side, even a child, helping you with this, a teenager especially, helping you, they're quite good with some of these video techniques. The next one is how we set up for a lower body evaluation. And here what you can see is that she's moved the device down to her feet, and now we're seeing from knee down. And so this is good if we're asking folks to do tasks or if we're looking for chorea in the feet. With the walking, a lot of times I'll have folks set it up at the end of a hallway. And what you're going to do is kind of walk to and from the camera in the hallway. And you can see this is a nice view. This is Dr. Kirby here demonstrating for us. You can see her entire body walking. And this is really important for Huntington's disease because the problems with walking that we see in Huntington's are variable. And so we may treat different walking problems differently with medications. And so it's really important for us to be able to see what's going on. Now last, this is a little bit about lighting for the telemedicine visits. And what we find is that the lighting is done best if it's done in front of you rather than behind you. So in fact, right before I started talking to you today, I shut all the curtains behind me because I have a lot of light coming in the window, a little unusual for this time of the year in Chicago. But what you can see is if you look at Dr. Kirby here on the lower right, you can see the difference between the light behind her and the light in front of her. And I think it's really important for us, especially to see chorea in the face or the neck region, and to look at tongue protrusion or eye movements, that we have good lighting. Now, I just want to make a comment here. Many of our Huntington's patients that we've been seeing via telemedicine are late-stage Huntington's patients. And this has been a great opportunity for us to see those patients who have a hard time getting into the clinic. Now, many of these techniques are going to be hard with the patient, especially who is bedbound. And so in those situations, we would prefer to have somebody holding the camera and obviously the person, capturing as much information as we can from that person who's bedbound or who's in a wheelchair. I do think telemedicine, I'm hoping it's around to stay for those late stage patients because we've had access in a way that we haven't before. And we've been able to do a really good job of providing in-home care, other resources to folks who might have had a hard time getting those prior to the pandemic. So I guess that's one of the positive things that's come out of the last year. All right, so let's just mention a little bit about sleep. Now, sleep problems, although they may not be on your list, it's not in those 3 buckets of things that I just described. It is incredibly important to know what's going on with your sleep for us to make decisions about medicine. Now, many patients with Huntington's disease, and in fact, the general population has difficulty sleeping. And it could be that, there's an issue with insomnia. It could be that people are able to fall asleep but wake up and can't go back to sleep. It could be that the sleep is very fragmented and people are getting up very often. So because of this, it's important that you think about sleep and even write it down prior to your visit and write down what the exact issue is. Now, the way that we prescribe medications for Huntington's disease, we will pick and choose medications depending on what's happening with sleep or other symptoms. If patients have a hard time falling asleep, I'm definitely going to pull certain medications out of my bucket to give them for the movement disorder as opposed to other ones. If people, in fact, are not having issues with their sleep and they're actually doing very well, I may choose not to use a medication that impacts sleep at all. So this is really important for prescribing. And when I was chatting about doing this talk, our psychiatrist said this may be the #1 symptom for him to ask when he's making a decision about what to prescribe. So let's talk a little bit about being ready as far as your medications. Now, many of you know and bring with you a list of the names and doses of the medications you're on. But in fact, I think as you're getting ready and trying to get organized and you get in for the visit and fight the traffic and try to make it on time, many folks will leave the list in the car or they'll forget that they had a medication change last time. And in fact, the best thing to do, I think, is to write it down on a form you can either print out or you could write it down and take a picture of the list on your phone. And that way you've got it with you. You can always take a picture if the list gets updated. Now, providers are not necessarily going to know if you describe the pill, what the appearance of that pill, which pill that is. Now, some of them are always the same, especially if they're a new medication and there aren't generic versions yet. But for the most part, writing down the name and the dose is very important. There's also frequently questions about what medicines you've been on in the past. So I'm going to make a decision about a current prescription based on side effects you may have had from medicines before. We definitely don't want to repeat a medicine that you've had problems with. So this list of medications is really important. Now, pharmacists can help. A lot of them can do a printout from the pharmacy if you get all your medicines from the same place. It won't have the side effects on there. You're going to have to remember that, but the pharmacist may be able to help you with the printout. Now, if we change your medicine at the last visit, we're going to want to know what happened. Did you get better? Did you get worse? Are you the same? Because that's going to tell us, do we need to increase the dose? Do we need to lower the dose? Do we need to stop it and start something else? So you definitely want to make sure you think about the medications before you come in, and that'll make those conversations much easier. Now, I want to go back to the sleep side because we've had a question come in about mirtazapine. So mirtazapine is a medication that's used for a number of reasons. We will use it for sleep, and it's also a mild medication for mood, especially depression, and doesn't really work that well for anxiety, but sometimes we'll use it in patients who have both depression and anxiety. It's a mild medicine, and we will sometimes pull it because it also increases appetite. And this is really great for patients with Huntington's disease. Mild helps people fall asleep. You give it at night before bed and increases appetite. Now, in patients who have kind of severe sleep problems, mirtazapine is going to be too mild for those people. So we're going to have to probably pull something a little bit stronger. Or think about combining mirtazapine. A lot of times we'll combine mirtazapine with melatonin, or if it's just not working, we'll stop the mirtazapine and give something a little bit stronger. So in fact, yes, we do use it for Huntington's disease for sleep, but it has the added benefit of some of these other improvements as well, mood and appetite. Thanks for that question. All right, so let's talk for a minute about supplements. Don't forget to tell us about your supplements. Sometimes the supplements will cause us to change what we're going to do as far as prescriptions, or some supplements can cause side effects. And if we don't know you're taking them, it may cause us to be have more of a challenge in sorting out what to do with your prescriptions. Now, in Huntington's disease, there fortunately have been several studies looking at various supplements. Now, unfortunately, none of them have panned out to be effective. So the ones that have been shown in good studies are coenzyme Q10, antioxidants, vitamin E, idibinone, and creatine. And these have all been studied in Huntington's and shown not to be effective. Now, some of these have been shown to be effective in other diseases, such as coenzyme Q10 and cardiac disease. And so, in fact, your primary care doctor may recommend you take some of these for other reasons. They're not harmful unless they're in high doses, but in fact, we don't have any good data to show that they're going to slow down or change the course of Huntington's disease. Now, there is a question about whether or not fatty acid supplementation could be beneficial. And in fact, there was this study looking at EPA, which is a compound that is used to treat high triglycerides. And in fact, this particular compound showed in a small series of Huntington's patients to improve their movement. So in fact, their movement got better, but on the flip side, their behavior got worse. And so it's really not clear, probably until somebody does a larger study, whether or not people should be buying this over the counter. Now, I will say that some of these supplements, such as the CPA supplement, are a bit more expensive than your standard supplements you would get at the drugstore. So in fact, we probably want to have a little bit better information to give you before you add this to your daily routine. Now, this particular supplement, the second one, triheptanoin, in fact, improves some of the imaging that we see in patients in Huntington's disease. Now, the imaging, yes, it can correlate sometimes with the cognitive or the movement disorders of the patient. It's really not something we treat. We don't see a Huntington's patient and say, oh, the scan's abnormal, I'm going to treat the patient. We really treat the patient because of their clinical symptoms. So I wouldn't necessarily recommend a supplement that changes imaging unless I had some data to show it's really going to improve quality of life or help something that the patient's going to find useful on a day-to-day basis. Again, larger studies are going to give us more information about this. Now, I just want to make one more comment about fatty acid supplementation. Why in the world would this work? Now, there's a lot of research going on right now about the microbiome or the gut in neurological diseases. And we now know that there's a very close connection between the gut and our brain function. So fatty acid supplementation and prebiotics, probiotics, all of these sorts of things that are available over the counter, in fact, will modify the gut microbiome. And in fact, that could lead to a change in neurological symptoms. We see that in other movement disorders. And probably the best data for this is in Parkinson's disease. So I think that this is probably a story that's going to continue to develop. I know that the HDSA series has had some talks related to gut. And so I'm hoping that, in the next few years, we're going to learn a little bit more about these things for our patients. Everybody likes to talk about marijuana. And in fact, in Huntington's disease, we do have a lot of patients who are using marijuana or marijuana products. So we're going to ask you, are you smoking? Are you using edibles? How often? What is the dose? Where are you getting it? Now, it's very hard sometimes to understand what the actual dose that people are getting of marijuana. And the reason why is because, as you're smoking, especially you're smoking marijuana, you don't really know how much THC and how much CBD you're getting. Those are the two compounds of marijuana. Now, medical marijuana does have effectiveness, and the THC, which is the part that makes you feel high, has been shown to be effective for pain, for nausea and vomiting, and for weight loss. And so, in fact, for patients who are on chemotherapy for cancer, the THC in medical marijuana is likely what's helping those patients with their appetite. However, that particular part of marijuana may be what is associated with cognitive decline in patients who have neurological diseases. So there's been some very good studies, especially in multiple sclerosis, that tell us that if you use marijuana on a daily basis, you may kind of lose some IQ points. And so we want to be a little bit careful. Now, CBD has been shown to be effective for seizures and anxiety. So if you're taking marijuana or marijuana products for anxiety, in fact, you might want to use a pure CBD compound. Now, I would not necessarily recommend that people use these regularly, but if you're going to use one of these products, pure CBD is probably the best way to go. Usually you can get those at a dispensary. And obviously there's a lot more dispensaries now than there were even a few years ago. In Huntington's disease, there have been some studies looking at CBD, and in fact, there was no improvement at all in the chorea or other movement disorders. There was a study with 3 patients with CBD at 600 milligrams, which did improve chorea. Now, nabilone, which is a synthetic cannabinoid, a pill form of marijuana, did not show any improvement. So what does this tell us? It tells us we probably just don't have enough information to know. There are potential drug interactions between marijuana and CBD products and prescription medicines, and we don't quite understand those interactions. So a lot of times what we'll do is try to monitor patients if they're going to go on one of these products and they're already on prescriptions. All right, so I wanted to circle back to one of the visits we'll frequently refer for, and that's a neuropsychological visit. And I get this question a lot in the clinic. Why do I need to go see the neuropsychologist? So who is a neuropsychologist? What do these people do? So this is a PhD psychologist who provides assessment and intervention to patients. So their first role is to kind of assess cognition. Where do people stand as far as their memory, their thinking, their executive function? This will help us clarify diagnosis and tell people what stage they're in as far as Huntington's disease. Now, the other thing that they do very well is counseling, and they can counsel folks with an emphasis on neurological diseases. And I think that this is really important, both at the time of the pre-symptomatic visit, but also at the time that the symptoms start in both mild, moderate, and severe disease. Now, our neuropsychologists will frequently meet with both the patient and the caregiver or spouse. And I think that that's very helpful in trying to understand what is the goal of the visit, and to try to kind of really dig down and understand what the issues are that need to be addressed. If the patient is seeing a neuropsychologist for counseling, that counseling needs to be on a regular basis. So a lot of times our psychologists will book those follow-up visits at the time of the first visit at a regular interval. Typically for a neuropsychological counseling visit, you're not going to get very far with one visit. You're really going to need to establish care and continue to see that person over time. And the nice thing now is that we can do that first visit in person and then do all the rest of it with telemedicine. And so that's another kind of bonus of the pandemic situation. We hope it sticks around after the pandemic's over. Now, people can get a little bit frustrated with the cognitive testing. So I just wanted to talk through this a little bit more with folks. So the cognitive testing usually will run about 60 minutes or more. And this is going to be an interview with the neuropsychologist. Sometimes they'll have a student with them. And they're going to ask you to take several pencil and paper tests. Now, some of these are going electronic, but I think most of us are still old school with the pencil and paper. And they're going to look at various portions of your memory and your thinking. This will tell me, the neurologist, what parts of the brain are affected in a particular patient, and will also tell me where I need to target my therapeutics. And so if the patient has dementia, that may be something we're going to address a little sooner than if the patient really has major depression causing memory disorders. So it really allows me to provide better care to my patient. Psychiatry is not uncommon, the need for psychiatry in Huntington's disease. And so when do we refer to psychiatry? So in symptoms that are hard to treat and that fall in the realm of the psychiatric specialties, such as psychosis, we'll tend to refer those patients over a little bit sooner. And, many patients will have an underlying psychiatric diagnosis prior to Huntington's disease onset. So people will be having depression or anxiety disorders that were there long before the Huntington's disease symptoms started. And sometimes we can't sort out what's the Huntington's and what's not. But in fact, our psychiatrists can help us manage these diagnoses as they worsen with Huntington's disease. And then, of course, if there's issues with suicidality, that's another time that we're going to refer to psychiatry. Now, many of you may be thinking, oh, it's really hard to get in to see a psychiatrist, or I haven't been able to find the right person that my insurance covers. So my prior practice at the University of Colorado, we didn't really have a psychiatrist I could work with very closely. And in that situation, I did a lot of the psychiatric management myself in the neurology clinic. So some of the neurologists will be treating a lot of these. Sometimes the primary care physician will help a little bit with depression and other things. I think that once it starts to get complicated, referral to somebody who is an expert in these areas is likely to be best for the patient. So let's talk a little bit about referrals, especially to ancillary services. So many of you, when you come into the clinic, may leave with a prescription for one of these therapies. It's not actually a prescription for medicine, it's a prescription for something else. Physical therapy is incredibly common when patients start to develop walking difficulties. Occupational therapy is specifically to help with those activities of daily living, like this patient is doing in this picture. They're working on things to improve fine motor movement. We also may refer for devices that will help with eating or safety. And sometimes, I'll send folks over just to get a specific wheelchair prescription. So sometimes, these folks can help in a way we can't in the clinic. They'll have items that you can test out in their practices that will allow them to kind of recommend to you what would be best. Speech therapy for both speech and swallowing evaluations are real common, and nutrition referrals happen as well. Much more so actually in the HD clinic because of the weight loss that we see with many of our patients. Rehabilitation doctors, we do use, and I think that many times when I say I'm going to refer to physiatrist, I get kind of a puzzled look from folks. So these are doctors who are specialized in either helping people recover from injuries or helping with a specific activity such as a wheelchair prescription. Last are social workers. So social workers can help us with resources, especially for our caregiving. So if someone needs respite care or if someone needs a specific service in the home, the social worker will help us organize this. Now, the best thing to do for caregivers is to have an understanding what you need before you come. And the more specific you can be, the easier it will be for your provider to kind of get you hooked up with the right person. Last, our social worker will help us with disability. How do you apply? How do you find a lawyer? In fact, we have business cards here in the clinic for folks if people need a referral for lawyers that have been helpful for our patients in the past. So I see we've had a question pop up as I've been talking. Do you happen to have a generic list of exercises or things to keep mobility and motor skills up? So I think the exercise prescription is different from patient to patient. I do have a general recommendation that follows the American Heart Association, and that's 5 days a week for 30 minutes of vigorous exercise. And so what is vigorous exercise? Well, it's enough to break a sweat, to be a little bit short of breath. And I think that many times patients will need a little bit of a ramp up to that 30 minutes and a little bit of a cool down. So it ends up being a little bit more like 40 minutes. Now, there's all sorts of issues with exercise. Many of you know nobody likes to exercise, right? Whether you have Huntington's disease or not. And when you add on a neurological disorder that causes apathy, this can be very hard. Now, many of us have been doing exercise via the web, internet classes and those sorts of things. And that can be good right now during the pandemic. But when the pandemic's over, actually having the patient go into a gym is really a good way to have some socialization outside of the home. And so if people can, especially if they're joining a gym for the first time, they'll frequently get some free training visits. The trainers are very good at putting together specific exercise programs for people. So what I recommend in those 5 days a week of exercise, I recommend that you have a day of rest in between your 5 days, so you're not going 5 days straight. And I recommend a combination of aerobic and non-aerobic exercise. So the aerobic exercise could be low impact or high impact. It could be running on a treadmill. It could be on a stationary bike. It could be on a recumbent bike. It just depends on the patient's balance problems. The non-aerobic exercise, if you're trying to change your body in some way, then lifting weights is going to be the most effective, the fastest. And so we would recommend weightlifting that will involve both upper and lower body, and that will involve multiple reps. So you're really kind of getting a good workout. So in addition to aerobic exercise and weight training, there are a whole host of other things you can do. So if people need to work on their balance, I would recommend Tai Chi, or yoga. That will help with that. And those things will also help with flexibility. So I think usually what I'll be doing in the clinic is I'll ask the patient during the interview, are you exercising? What are you doing? And if the patient says, yes, I'm swimming 3 days a week and I'm going to PT the other 2, that's probably sufficient. So it just depends from patient to patient. And I think there's some good resources available by various groups that treat neurological disorders, but I really think that exercise regimen needs to be individualized. So really you should ask your provider as you're going in. All right, so let's talk a little bit about nutrition and weight loss. So weight loss is a real problem in the Huntington's clinic, and I think it's much more so in the Huntington's patients than any other population that we see in movement disorders. So frequently I'll be asking, how much weight have you lost, over what period, what are the strategies that you're using? And we do have some recommendations of eating small meals, setting a timer, scheduling eating around activities, stocking the pantry. As the disease progresses, you want to provide small bites and kind of help your family member make sure they're chewing their food so there isn't choking, and adding in those high calorie, high protein foods that are healthy. And I have a picture of some of those on the right. We do moisten foods, and then we thicken liquids later as patients start to have problems with swallowing. So if we're having a lot of problems with weight loss, we do give out high calorie recipes in the clinic, or refer to nutrition, and they can help us pack those calories in. We do lots of shakes. You can put lots and lots of calories. You can put 1,500 calories in a shake. And so we'll ask family members to help with that. So for physical therapy, I will ask when the last time they had physical therapy was, especially if they're having balance problems. And then of course, we've already talked a little bit about exercise from the question that came up. I'm a big proponent of both of these. And so most of my patients will get a referral for physical therapy at least once a year if they have a balance disorder. And then here are my recommendations for exercise. And what you can see is exactly what I said as far as the various types of exercise that we can do and facilitators for exercise. So here are some of the resources that we pull and use in clinic. And I will say that the Huntington's Disease Society, even more so than some of the other organizations we work with other diseases, have a whole host of resources that we will use. Everything from how to talk to your children to caregiver guides for earlier and later stage disease. So we have these available in the clinic, or they can be ordered from the HDSA. And I think that these are really wonderful resources for people. I also just want to comment on end of life planning. And I think it's really important to think about this early, before we're at the end stages of disease. And this packet, the 5 Wishes packet, is a packet you can fill out and give to your care provider that will talk about medical power of attorney and what you would want done if you're ever in a situation where you can't make those decisions yourself. So that's a resource we use a lot in the Huntington's clinic. And I think it's a good resource for folks to think about earlier in the disease. So just a few more slides here. Now this slide is about COVID recommendations. And so I'm telling my patients, kind of follow the guidelines and the CDC. Many of our HD patients have not been vaccinated yet because they're under the age of 65. And in the state of Illinois, they're not able to be vaccinated. We're hoping at the end of March, we will start vaccination for Huntington's disease. I am recommending that people stay socially distanced. Unfortunately, we have lost Huntington's patients to COVID. And so we want to, I'm telling folks just to postpone going back to the gym until they're able to get vaccinated. I will tell you it's much safer to come into the clinic now than it was even 6 months ago because all of us have been vaccinated. So at least we're protected on one side here. Now, as far as vaccination, vaccination has been tested in lots and lots of people at this point. In our practice, we're recommending all Huntington's patients get vaccinated. And both of the vaccines that are available, and obviously I made these slides before the J&J vaccine, are 95% effective. I am recommending people pre-medicate, especially after you receive the second dose in order to prevent side effects. I know I got 101 fever after the second vaccination, and as soon as I took the Tylenol, I felt fine. All the symptoms went away. Research visits, these are very common in our practice. There's a whole host of different types of research you can do. If you ever wanted to give back to the HD community, in addition to potentially helping yourself, this is the way that you do it. And I've really seen the generosity of Huntington's disease patients and families to give back to the next generation by participating in research. Whether the study is observational or whether you're going into a gene therapy study, you're helping us, you're partnering with us as a team to learn about the disease and try to get some of these medicines on the market. So I would talk to your provider about research. If you're not going to a Huntington's Center of Excellence, there's not a lot of research going on. It's very likely your provider can hook you up with someone, and maybe you go a little less frequently for your research visits, but I think giving back to the HD community helps everybody move the field forward faster. Now I've got this oh by the way slide because this happens a lot on our clinic visits, that right as you're getting ready to leave, another topic comes up. And I would recommend that you bring these topics up early, even if they're embarrassing and you kind of want to leave it to the very end. It may be that the provider needs to tailor the visit a little bit to gather more information. And so you want to make sure that the provider has time to do that. And I find that these are some of the by the way questions, oh by the way. Questions about sexual function or inappropriate behavior, hallucinations or delusions, details on toileting or urination, marijuana. So these things will happen as we're leaving, and I'll turn around and sit back down. We'll have another conversation about it. But for example, sexual function or inappropriate behavior, that may be an opportunity for me to say, oh, you know, my neuropsychologist is open, let's get her involved, or my psychiatrist is going to have to address this, let me get him involved. And then if that's the case, earlier in the visit is better than later. Last, we will get the request to talk to us about something, but not in front of a family member. So I think this works best when you let us know ahead of time, even at the time that the medical assistant's checking the patient in. You just to pull aside the medical assistant and say that you want to let the doctor know you want to chat with them. And then we can time it either before or after the visit. Now, if there isn't an opportunity to do that, handing the medical assistant a note can work too. And if you have details of what you want to discuss in the note, that can be helpful. So I would, do whatever seems appropriate to you, but we will frequently do this to accommodate our HD families. So I've had a couple questions through the chat. This is our group at Rush University. This is what Rush looks like if you're not in the Chicago area. And we're proud to be number 4 in the country right now. So we're very happy about that. So I'm happy to answer any other questions. So send them through the chat.
I want to remind folks that all of the HDSA publications, the ones Dr. Hall showed on her slide, as well as a library of others, are available online for downloading. So you don't necessarily have to get a physical copy of it from HDSA. You can download it for free by going to hdsa.org/publications. And you'll find the physician's guide, the caregiver's handbooks, understanding behavior, as I said, just a whole wealth of publications and information.
And I had a comment from one of our attendees about studies. So that's great. Any other questions or comments? Okay, so I have a question. Is pain something the neurologist will address? So that's a great question. So pain is definitely a component of the disease for many patients with Huntington's disease. And I would say that it depends, and that's probably not the answer you want, but it kind of depends on the nature of the pain. So sometimes the pain is related to another symptom. So for example, I had a patient recently who was having a lot of pain and crying out. And what we discovered is that she wasn't getting enough calories. And so she was kind of hungry and she wasn't able to communicate very well. And so she would kind of call out. And we thought it was a pain issue, but in fact, it turned out to be an appetite issue, or actually that she was hungry, not getting enough calories. Another example might be, somebody has nerve pain in their legs, and the nerve pain maybe happened prior to Huntington's disease, but is sticking around. So nerve pain, we have good medicines for nerve pain. We can prescribe those. So it kind of depends on what the pain is. And I think what the neurologist will do in most circumstances is to try to dig in a little bit deeper. Do you have a pain from a frozen shoulder? If that's the case, then, that person is going to benefit most from physical therapy or massage in order to break up that shoulder. Do you have pain from, head pain? Do you have chronic headaches? Do we need to think about treating you or treating triggers for headache? So I think because there's so much pain, causes. I think what we need to do is individualize it a little bit and do a kind of a pain history with each patient, and then see if we can target the therapy based on that. Okay, so it sounds like the person who asked the question, I have pain from an old car accident and new pain from constant hand and feet and jaw movements. Okay, so if there's pain related to the movement disorder or pain from a prior injury, I think those could definitely be addressed with the neurologist. Sometimes if you're having pain, say you have dystonia, you have a movement disorder and you have pain, sometimes if you treat the underlying movement disorder, the pain will resolve as well. And so, you know, again, I think having the neurologist get as much information from you as possible is good. Now, if you have pain to the extent at which you need narcotics, many neurologists do not prescribe narcotics. So if we get to the narcotics point, frequently the neurologist will refer on to a pain specialist who's very well versed in narcotics. If you need injections, steroid injections or other things because the pain is more joint related, then of course there would be a referral to a pain specialist or orthopedic person who does those. So I hope that answered your question. And then there's another question here about CRISPR-Cas9 studies coming down the pike that I am aware of. That seems to be an answer to this super difficult disease. So I know they're doing work in the lab on CRISPR, but I have not seen any early human clinical trials yet. There may be, but I haven't seen anything. There's kind of, I think, a lot of ethical issues about CRISPR. So I think as they go into human trials, I think that, you know, they may be slowed in some ways by FDA until those issues are sorted out. So in fact, I think it's very promising that we have gene therapy studies going on right now. When I did Huntington's disease 20 years ago, there was nothing. We didn't have any medicines on the market. We didn't have any research studies. And in fact, now the gene therapy studies show real hope and promise for us. And, you know, hopefully the Roche Genentech study will be done in 2023. We'll have some idea if that has any impact on disease. And Unicure is starting their surgical study. So I think there's great hope. Even if the CRISPR story isn't the solution, we may have hope from some of these other gene therapies. Okay, so there's a question about Dr. Wall's protocol diet. I'm not sure that I'm familiar with that. Whoever asked the question, I think it was Ryan. Do you want to tell us a little bit about that diet? We'll give him a minute to see if he tells us anything about the diet. Okay, there's another question by Sharon. Are you optimistic about? So Sharon, if you want to add a little bit more to your question. Oh, are you optimistic about ongoing studies? Yes, I am optimistic. And I think even if the current gene therapy studies aren't successful, they are the beginning of something very exciting in Huntington's disease. So, you know, I see a lot of other neurological diseases, and we've had some major successes in other brain diseases for the first time with gene therapy. And so I really think that we have an opportunity in Huntington's. We know the gene, we know what's going to happen, we know the time frame, and we're starting to learn how we can fix it. And so there is a lot of interest in the biotech community and in the pharmaceutical companies in trying to sort out the underlying problem and to stop or slow progression of disease. So I'm incredibly optimistic. I'm optimistic for the HD patients and families. I hope within the next 5 years, we have something we can offer on a clinical basis. I will tell you, if you want it sooner, go into one of these research studies if you qualify, and you can help us get it on the market even faster. Ryan, I don't think you're going to be able to unmute. Do you think the therapies will be available for those of us who are in early stages? So in fact, the gene therapy, especially the surgical gene therapy for Unicure, is being offered only for individuals who are in the early stages. So I think, you know, if you're in the early stages, you may be the exact target for the clinical trials in this area. So I would reach out. Now, what I suspect will happen is that the therapies, like other disorders that we have done research in, the therapies will be approved first by FDA for patients with symptoms of the disease. And if that appears to be safe, they will move back and test it in patients who may be gene positive but don't yet have symptoms. Now, other neurological diseases have followed this pattern. We always want to make sure that it's worth the risk, right? So if you don't have any symptoms, but you're gene positive, we don't want to give you a medicine that's going to make you really sick. And so, I think that the strategy is to get the medicines approved for the right population first, and then they'll expand that population of who they're going to give it to. Okay, so we're hearing a little bit more about this diet. Dr. Walls is a doctor that had multiple sclerosis and was wheelchair bound and used food as medicine and has been able to walk, cross-country ski, ride a horse, etc. Pretty amazing story. I'm not familiar with Dr. Walls and his diet, so maybe I'll take a look at that. Any other questions from the group today? Okay, I'm not seeing any other questions. I'm going to turn it back over to Deborah and HDSA. Oh, wait, one more question. I am always confused by what is symptomatic. Okay, so symptomatic is when you have a symptom of Huntington's disease. It could be any symptom. So the easiest way to tell that you have symptoms is if you develop the movement disorder, because you can see that, your family can see that, your friends can see that. That's the chorea, the little jerking movements. If you have a symptom, say personality change, that's a little harder to know. Is that the beginning of Huntington's disease or is it something else? And so at the very beginning, for the very first symptom, if it's not the movement disorder, it may be a little harder for us to understand. If you're not sure, I would just go in and get seen, especially if it's a symptom that's bothering you. So say you're more irritable than you used to be. People will come into the clinic, I'm more irritable, I'm gene positive, but I don't know that I have any other symptoms. We say, let's help you with the irritability. And whether or not that is Huntington's disease, we may not know, but we're going to try to help you anyway. And so symptomatic, really, again, it can be sometimes hard when you're just developing symptoms of the disease, but I would say come in and get seen and we'll try to help you either way. And then there was one comment about lasers, and I don't know the data behind that. So I'm going to probably leave that for a later talk. So I'm going to turn it back over to Deborah.
Thank you so much. I certainly learned a lot during this session, and I'll be using it when I go to see my primary care provider in a few months. So thank you very much for this informative talk. There was a lot of information that was provided today, so I want to remind folks that this broadcast will be available on HDSA's YouTube channel in about a week. I want to thank Dr. Hall for the time that she put into this presentation and for joining us today. I know that there may be some questions that weren't answered, but we hope that we'll get it in a future broadcast. I do want to remind folks that on March 18th, we'll be welcoming the team from our HDSA Center of Excellence at Washington University School of Medicine. We'll be talking with us about confidentiality and the electronic medical record. Until then, take care, stay safe, and thank you again, Dr. Hall.
Hi, thank you.